I'm Dr. Leigh Haysom. I'm the Clinical Director, Adolescent Health, and the Director of Medical Services for Justice Health. I've also got Caroline Nyongesa, who's a PhD candidate from the University of Newcastle, who'll be presenting some research we're collaborating on a little bit later. And we've got Dr. Nicola Sutton, who's here, who's part of that project as well. And today we're actually doing some of that research at one of the centres. So I'd also like to acknowledge the traditional custodians of the lands. Today, Caroline, Nikki and I are on Darug country, and this is the Gomeraigal and Tongara clan. We're actually in St Mary's in Western Sydney. I'd like to pay my respects to the people of those lands and to any Aboriginal people who are joining us today. So just to begin, to give you a little bit of context of the youth custodial setting, there are 6 youth justice centres across the state. So this is a map of all of the correctional and youth justice centres in New South Wales. On the right is a cutout of the metro area. So we've got 3 metro centres. There's Frank Baxter in Gosford, St Mary's where we are today, in Cobham, Blacktown, St Mary's near Blacktown, and we've got the Reeby Centre at Campbelltown in the southwest. And our 3 rural centres are at Camina, which is in Grafton, Arana in Dubbo, and Riverina, which is in Wagga Wagga. There's also a number of other centres that are not correctional centres, but we've got offices that we share with Youth Justice, with our community integration team. There's a court team, and there's a number of other teams scattered throughout the state to look after people who are involved in the criminal justice system. And currently there's, I think, around 260 odd young people in custody, which is about average for this time. Back when I started working for Justice Health quite a few years ago, there were almost 500 young people in custody, so things are relatively better in that space, although we did have record low numbers of about 180 during COVID, and gradually things are picking up again, and currently in a bit of a political climate where the numbers are gradually creeping up, and we do have very high rates of Aboriginal young people in custody. At the moment it's about 65%. So who are the young people in custody? You know, at the moment we've got about 260 young people in custody, but the flow through is a much larger number, and there's actually around about 3,800 young people who come into contact with the criminal justice system in any year. We make meaningful contact with any young people who stay longer than 24 hours in custody, which is around about 1,800 young people a year. But yes, acknowledging there is a much bigger group who we don't make contact with, unfortunately, and they're just as needy. So it's mostly young men, about 92%, with 8% young women. They range in age from 10 through to 21, so the minimum age of criminal responsibility, sadly, across Australia, except for Victoria, is 10. Northern Territory did go up to 12, but they've rescinded that back to 10. Victoria increased the age to 12 a little while ago, but they're bringing in some new legislation which may increase the numbers vastly in their state. And these are very disadvantaged young people. There's very high rates of child abuse and neglect, out of home care. Many of the young people have had one or other, both parents who've been in custody. This is a bit of an old slide. We currently have about 65% Aboriginal and Torres Strait Islander young people in custody. High rates of risky drinking and illicit drug use, lots of specific physical health issues, and very high rates of psychological issues and intellectual disability. On the right of the slide are the directorates who look after the young people. Obviously there are other directorates such as oral health and population health who also provide services to the young people. And the custodial environment is quite confronting, although it's a little less confronting than the adult system. So the young people are housed in units. At Cobham, I think there are about 7 or 8 separate units. There are a lot of gates and fences, and unfortunately there is razor wire around. And within those units, the young people have their own rooms, but they're actually cells, and they do dine together communally, which is one good thing. So within each of the units, there are these dormitory wards where the young people are housed. They have to wear green, although there are sometimes other colours between the units. And yeah, they're very, very bare accommodation suites. There's a shower and a toilet. They have a TV, and there's not a whole lot else. And they're usually housed one out. It would be very unusual to have two young people housed together. So barriers to research within this very complicated and restrictive setting. I mean, some of the issues are what you all experience as researchers, but there's a lot more gatekeeping and limited access to young people, and a lot of that's got to do with the operational demands of a very busy prison schedule. There's often a lot going on within youth justice centres. There are, resource limitations for clinicians doing research because there's not a lot of investment or funding by Justice Health for clinician researchers. There are issues around, getting access to data and who owns the data, and particularly when you've got a majority Indigenous population, there are sovereignty issues to consider. And, any institution in this kind of environment, there's a lot of distrust and stigma by the people that we're looking after. There's also a lack of awareness by them about research and what it can offer. There's low health literacy and comprehension of the sorts of health issues that we're investigating. There's competing priorities for people in custody because they've usually got lots of things that they have to juggle and navigate while they're here. My agenda as a researcher may be very different to what the board wants in terms of research. And, there are those other ethical and regulatory issues around people who are incarcerated being very vulnerable to things like coercion, types of research that gets conducted. There's historically, a number of atrocities that have been conducted through research with people in prisons, and we could, do a whole talk on that. And there are problems around compensating people for their time in research and, trying not to make that coercive. And then you need to balance the protectiveness of the person's rights versus their right to participate in research. And because we have, high rates of intellectual disability and often significant mental health issues, there are issues of capacity to consent. And there are also some very young people in custody as well, and, working with their carers to consent them for research if it's appropriate. Whoops. So I'll just talk firstly for a little while about a translational research project that I've been involved in, and then I'll pass over to Caroline to talk about her research that we're assisting her with. So I collaborated with the Western Sydney University to look at vaping and smoking behaviours of the young people we look after in custody. So as you know, vaping is a big issue for Australia. We kind of entered the vaping space quite late compared to other Western nations, but we took off like a rocket. And up until the time where legislation was being considered, we were positioned to overtake all of those countries in terms of rates of uptake amongst young people for vaping. And the highest rates, as we know, are within that 18 to 24 age group of young people. So obviously it affects the young people we're looking after in custody. So we hadn't really been taking much notice of vaping of young people who were coming in. We didn't have any systematic approach to it. So we decided to do a whole of health collaboration. So we got some Sydney University MD students involved. We sought the advice and consultation of the Babain Aboriginal Corporation in Western Sydney, and Adolescent Health, Pharmacy and Population Health collaborated with the Cancer Institute of New South Wales to come up with an approach to vaping that was a population-based approach. So we introduced some questions around vaping that went alongside the other smoking questions that we have in our initial assessment. So any young person, as I mentioned, who stays in custody longer than 24 hours has to have a full assessment which involves a very lengthy process. It can go over a number of days, and it's based on the head's assessment for young people, which is a comprehensive and holistic assessment of their needs. So we asked them about their vaping, how old they were when they started vaping, how many days a week, and the sorts of quantities that they were vaping. And we found that, and this was a 6-month period that we conducted between February and July 2024. So this antedated any of the legislation that was yet to come. And over that period of time, there were 474 unique initial assessments. 12 young people declined to participate in any initial assessment, which left 462 records. They were about 81% male and 62% Aboriginal and Torres Strait Islander youth. And of those young people, 61.3% were regularly vaping, 84% were daily vapers, and over 90% were using nicotine vapes that they knew of. The rest of them were using some sort of vape, which very likely also contained nicotine, as we know. And a reasonable proportion, so over a third, had tried to stop vaping, with more than half of them finding this quite hard to do. We also looked at nicotine dependence and attitudes to nicotine replacement therapy in vapers. And of the vaping young people, almost 55% were nicotine dependent on reception to custody, and that was using a standardised tool to measure nicotine dependence. And of the nicotine dependent vaping young people, less than half were actually being offered NRT on reception to a youth justice centre. So all of our staff, our nursing staff who do receptions for young people, are trained in how to offer nicotine replacement therapy, and they're actually able to prescribe it through a nurse-initiated medication protocol. But only less than half were being offered NRT on reception, even if they were nicotine dependent. And of those 48.8% who were offered NRT, only 58% accepted NRT, and we found that young women and non-Aboriginal young people were more accepting of NRT. We also looked at associations with vaping compared to non-vaping young people, and we found that being a young woman was significantly more likely to be vaping as compared to non-vaping. We also found that being younger you were more likely to be a vapor, and that vaping was more significantly associated with cigarette and smoking and cannabis use compared to the non-vaping group. We also found a very significant association with a high SDQ score in the vaping young people. SDQ is a strengths and difficulties questionnaire that measures adversity and mental distress, which is interesting because there is research that shows that anxiety, depression, and mental distress in young people is more associated with vaping. Just noting that there were a number of people in both the cannabis and the SDQ groups who declined to answer those questions. So, look, it's really obvious that vapes have disrupted the pattern of smoking behaviours in young people entering custody. So you might be aware, there are the young people in custody health surveys done in 2009 and 2015. And those rates of cannabis use and cigarette smoking were relatively similar, almost 90% cannabis use and around 80% of daily cigarette smoking in those young people over that period of time. However, since vapes have come into play, our study showed that, as described, regular vaping was 61%, cannabis use has come down a lot to 61%, and daily cigarette smoking has almost halved in the face of regular vaping. Also noting that co-smoking is a very frequent issue, and 3/4 of the young people are actually co-smoking, which means they're smoking and/or cannabis and/or vaping. We also asked the young people, what did you start first? So there were 317 young people who answered this question about their debut to any type of smoking behaviour. And we found that cannabis still leads the way in terms of young people are starting to use cannabis first before anything else. with cigarette smoking being the second most frequently debuted smoking behaviour, and vaping coming a third. An interesting hypothesis may be that this could change as time goes on. So the MD students also did some surveys with the staff and about their attitudes to NRT and using NRT. And our reception nurses had some interesting attitudes to NRT and to nicotine dependence and nicotine withdrawal. One of the common comments was they'd never observed a case of withdrawal strong enough to warrant NRT. They felt that young people entered custody with the intention to continue vaping after returning to the community, and that this decreased the nursing staff willingness to provide interim measures like NRT. And there was also a lot of concern about the misuse and diversion of NRT in the youth custodial setting. Other clinicians, so GPs, psychiatrists and clinical nurse consultants, were actually concerned about reduced access to NRT. They felt that our use of only the low-dose NRT patches was suboptimal therapy and likely discouraged uptake by young people. And they felt that there was no NRT availability for adolescents under the age of 14, despite those young people having nicotine dependence. And they were advocating for alignment with the PBS recommendations, which is to provide it for 12 years and upwards. Population health in Justice Health also did some really fantastic youth focus group feedbacks, and they looked at 8 groups of young people, between 5 and 10 young people in each group across the 6 youth justice centres, about vaping and the sort of media and messaging around vaping. And young people were reporting that there was confusing messaging from a variety of providers around vaping. They were feeling that vapes were harmless, and when they were asked about, withdrawals to vapes, they weren't recognising the signals about withdrawal. And, that may be because it's mixed up with withdrawal from many other different substances that they're using. They felt that the messaging from New South Wales Health on the left about vapes, that the vapers didn't look sick enough. They were really wanting messaging that told a story, had a connection to them, and possibly a shock factor. So a lot of the young people were offering the Dying Brian advertising that was around for smoking on the right there. We didn't show them that picture, but many young people actually nominated that as an effective form of messaging around smoking, which is very interesting. We also spoke to the Australian youth justice jurisdictions, so the 6 states and 2 territories were interviewed, and most Australian youth detention clinics had inconsistent approaches to nicotine dependence and NRT. Only 3 of the 8 jurisdictions had a public health approach in screening all of the young people on entry for nicotine dependence, and only 1 jurisdiction out of the 8 provided an evidence-based approach to treatment by offering a combination of rapid and slow release NRT in the form of lozenges and patches combined with brief intervention counselling for young people. So what are we doing in adolescent health about all of this? We decided that we needed to have a more standardised approach, so we developed a guideline for staff to refer to, and within that guideline we had a series of different pathways that both staff and more specialist staff could refer to when they were talking to young people about vaping and smoking. We also looked at our nurse-initiated medication prescription for nicotine replacement therapy. So as has been noted, the nurses were only offering lower dose patches to older young people, so we amended that protocol to make it for all young people 12 years and older, as per PBS recommendations. We also included all of the strength of patches, and we allowed the nurses not only to prescribe for 2 weeks, but they could extend the prescription for a further 2 weeks if it was taking a little while for that young person to then talk to the centre GP. And the GPs were encouraged to talk to young people about longer treatments, more akin with what's available in the community for those young people who are committed to giving up smoking and vaping. And we will be trying to introduce lozenges for young people so that they've got access also to some rapid acting NRT, but that will require quite a lot of collaboration and involvement with Youth Justice, because they will actually be the ones on the units offering that to the young people. Population Health also ran a World No Tobacco Day with the centres, and we got some fantastic artwork out of that. It was funded by the Cancer Institute of New South Wales. There were actually 40 entries, and it was a great way of involving the young people in messaging about vaping and smoking, and to learn more about the harms of vaping and smoking. And the health staff were also involved, and it was good for them to be seen in that space and be talking to young people about vaping harms. Pop Health also worked with young people and an artist to develop these beautiful playing cards, which does include some of the young people's artwork. And the cards also contain messages about, smoking, vaping, and giving up, what to do, with cravings, that sort of stuff. So those playing card packs have now been printed and produced, and the nursing staff are using them as part of their brief intervention counselling for young people when they're talking about vaping and smoking, and it's sort of an effective incentive for that process. We're also collaborating with different LHDs. So St Vincent's Health Australia offered us some training for staff. So Tracy Greenberg came and did that, and upskilled our staff in delivering brief interventions around smoking cessation, which was fantastic. We've been working with the Northern New South Wales LHD with their Culturally Adapted Clouded Minds program. That delivers culturally adapted versions of the Mid-North Coast Clouded Minds program, and this is being delivered at the Ecmina Youth Justice Centre in Grafton. And we're also speaking to other LHDs within where our youth justice centres are placed, and the Aboriginal community controlled health organisations close to them, to collaborate more on some of this work. So we did that study back in June 2024, which was prior to the Australian vaping legislation. The legislation was implemented between July and December. It actually started earlier in the year, but in terms of how it would affect the rates of vaping on our young people, that was effectively from a period of July to December 2024. And so I quickly crunched the numbers for that, which showed a slight decrease in vaping rates from 61% down to 57%. I also had a sneaky peek at the post-legislation rates of vaping from January to June 2025, and sadly, looks like it's actually higher, whether that's a significantly higher rate, but it certainly hasn't dropped. And I think this goes to the question of how effective that legislation is working for young people, particularly when in my suburb you see a vape shop, not called a vape shop, although some have been called vape shops, but tobacco and convenience stores just about on every corner, and often quite close to schools. So in terms of future research, we are going to look at the information we've been collecting since the legislation, and to talk a little bit more about that. I mean, there are options to talk with young people about the changing space of nicotine and zins and snus, which are being described now as the new vaping, and to evaluate staff confidence in delivering those brief interventions and NRT going forward, since we implemented the guidelines, the pathways, and the training. And that's me. There are a couple of publications there which I've highlighted that we got out of this work, and look it up if you're interested in reading a little bit more. And now I will hand over to Caroline Nyongesa.
Good afternoon. I will. Okay.
I was just scrolling.
You were just scrolling? There we go. So my name is Caroline, and my study is called Unlocking Smiles. It really focuses on improving oral health access in youth custody in New South Wales. I'm involved in an industry-based PhD study with Justice Health New South Wales, and Leigh is one of my supervisors, and Nikki, who's hiding at the back, has been very instrumental in helping my research. So to begin with, I also would like to acknowledge and pay respects to traditional custodians of the lands on which I work and live, and that is the Awabakal and Warramai people. I pay respect to the wisdom of elders past, present, and emerging, and extend that respect to all Aboriginal and Torres Strait Islander people here today. So my research proposal, or the overall aim of my PhD research, is to evaluate the 3 E's, and that is efficacy, effectiveness, and efficiency of virtual oral healthcare intervention in custodial settings. I have 3 main research questions, and I will be discussing the 3 today. The first one is really looking at the concepts and trying to understand how they have been applied and measured in in custodial settings or correctional facilities. The second research question really looks at the burden of oral health disease for young people in custody, and I'll explain why we moved from virtual healthcare to oral health disease specifically. And the third one is an intervention which we're trying to answer the question, can an asynchronous virtual care model be used to provide remote oral health care screening for young people? So the first study, because I have 3 key studies, is a systematic review, which has already been published. And it looks at the concepts, as I mentioned earlier, and really looks at how these concepts have been previously measured by other studies and applied. The second study is a retrospective data analysis, which looks at the burden and management of oral disease for young people in custody in New South Wales. And my third study, which is the one we're actually conducting at the moment, is examining the efficacy of a virtual care model within custody. So for the systematic review, what we aim to do is to understand the concepts. When I first started out, we really, the focus was looking at virtual healthcare within custodial settings, but with the literature, we wanted to understand how virtual healthcare had previously been examined, evaluated by other studies, and then build on that. So at the beginning was really defining the concepts, because a lot of the studies referred to effectiveness, efficiency, and efficacy, but they were not very clear on how this was measured. So that was the first aim. The second aim for the systematic review was to provide an overview of appraisal methods and measures that had been used to analyze the 3 concepts within custodial settings specifically. And we used a framework that is proposed by WHO. We actually adopted that framework and evaluated these studies in regard to this framework. So the framework primarily looks at digital healthcare, and WHO really provides a stage-based approach. So you look at the maturity of the virtual intervention and assess it with specific measures based on the stage of maturity. So for our systematic review, we searched 3 main databases. That's PubMed, Web of Science, and Scopus. After removing duplicates and doing the standard title and abstract screening and full text screening, using our inclusion and exclusion criteria, we ended up with 21 studies that we included finally in our systematic review. For the studies, maybe just a little bit on the inclusion criteria, we looked primarily at primary studies, that's peer-reviewed studies that used both mixed methods, quantitative, qualitative methods, and were focused to correctional facilities. So when I say correctional facilities, we excluded anything that was not in the context of correctional facilities, that is community service or even parole. We did not include that within the study context. I think aside from that, we also looked at all the studies where the author indicated that they evaluated efficacy, effectiveness, or efficiency, and provided measures that were gauged during the study. So like I said, finally, we ended up with 21 studies that we included in the final assessment. Just a quick overview of the findings. We found that majority of the studies were conducted in the US, which is commonly typical within the context of correctional facilities. Majority were focused on adult males and synchronous modality. So by synchronous modality, I mean online version, so real interaction. I'm trying to find telemedicine kind of setup, whereas asynchronous basically looks at store and forward, and synchronous looks at real time. And again, they focused primarily on medical specialties. So primary healthcare was not really included. In terms of defining the three concepts, no study actually explicitly defined the concept. So they used proxies to define the concepts, but not actually defining it explicitly. In terms of looking at efficacy, effectiveness, and efficiency, efficacy was often mixed up with effectiveness. So we'd find a lot of the parameters that we use to measure efficacy were also used to measure effectiveness. And from the 5 studies that actually stated they measured efficacy, we found that only one of them met the WHO criteria. Second of all, if you look on the table on the right, you can see the efficacy measures as user satisfaction, inter-examiner agreement, pre-post intervention differences, and improvements in clinical parameters. And you can also see the effectiveness measures are almost similar: user satisfaction, inter-examiner agreement. So that's what I mean by some of the studies actually use similar parameters to measure both efficacy and effectiveness. What WHO recommends is that this is okay, but it should be stage-based. So ideally, the parameters that measure efficacy are rather separated from the parameters that measure effectiveness. And when I say only 1 out of the 5 met the criteria, that's what I mean. Lastly, in terms of efficiency, there are actually very few studies that measured efficiency. Only 1 out of the 21 measured efficiency, which was a little concerning because we'd expect that in terms of cost that this would be important. Overall, the significance of this for us was just to help us clarify our baseline and help us to understand what had already previously been done. How this informed our study moving forward was really around the characteristics. We realized that because most of the studies were focused on adult males and medical specialties, our conversation with Justice Health at the beginning then kind of gravitated towards, can we focus on a younger population and primary healthcare as opposed to what other studies had done. So after quite a lengthy conversation, we settled on oral health because the justification was very straightforward. So for oral health crisis within prison, the first thing is that globally, oral disease affects half of the global population. And from the studies that we found that the rate of oral disease is higher in prison than in community settings. So if I move to New South Wales specifically, we found that about 50% of youth in custody have untreated tooth decay. And the impacts of poor oral health have far-reaching consequences, not just on health and well-being, as illustrated by the figure on your screen, but also other social, psychosocial and economic consequences, including employment prospects. So the sad part is that a lot of young people in custody have very limited access to dental care. And this is usually due to resourcing. With the conversations we've had, there are only 4.47 full-time equivalent dental officers within New South Wales system. And this caters for a population of about 12,000. And as Leigh had shown you all the different centers at the beginning, that gives quite a deficit in terms of access. The other thing we discovered was that there have been quite a number of studies that have evaluated virtual oral healthcare interventions in community settings within Western Australia that have shown significant success in terms of using these interventions to improve access. However, there have been actually no studies done in custody evaluating virtual oral healthcare interventions. So because of this, we went ahead to start understanding the data first and then proposing an intervention. So my study 2 then is a retrospective data analysis looking at the burden management of disease to date. And the first aim was to describe the prevalence of oral disease and understand the oral health outcomes of young people who had already accessed oral health care. And the second one was to assess the effectiveness of the current model of oral health screening and triage at reception. So for this, we have two databases. One is Titanium Oral Health Information System. So this houses primarily dental data and has all the data on all young people who had already been seen by the dental team. And then we have JES, which is the Justice Health Electronic Health System, where we focus primarily on reception screening and looking at oral health screening at reception. So the aim was to really look at the dental caries experience and the attributes of young people who accessed, or rather who reported a dental problem, and those who did not. The data spans from February 2019 to February 2024, and really looking at the social demographics and dental service information. We focused on 5 sites because one of the sites does not have a dental clinic or rather a dental chair. So they refer out to the local health district. So we have data for 5 sites. Participants are aged between 10 to 21. And again, we included any young person who had seen within that time period. The significance of this would enable us to quantify the burden of the disease and also use these findings to support the intervention. We were constrained by what was available and comparable across the 5 centers. So for the third study, which is a virtual oral health screening study, the conversation we had with Justice Health was, first of all, the dental team identified this as a high priority, primarily because of the long-term benefits of addressing dental care in a young cohort. So because we were looking at young people in custody, this would have far-reaching benefits in the long run. There's also limited access, especially for rural and remote centers, like I mentioned, like Akamina, which doesn't have a dental chair. This would actually be very useful for such a center. And the third one is that, and the other reason was that there are currently virtual healthcare services that are provided for adult centers, but not so much for the youth centers. So the main question is really, can this model be used to provide remote health screening for young people in custody? And the study itself, as I'd mentioned earlier, examines the efficacy of the model, aiming to evaluate the validity, reliability, and acceptability of the virtual health model. The design is really a diagnostic cross-sectional prospective study, which targets young people aged 16 years and over. Our sample size is 84, and we are focusing on 2 youth centers, that is Cobham and Frank Baxter. The intervention itself is an intraoral photographic assessment. So what we're doing currently is taking photos of the young people's teeth. These photos, I'll show you later how that procedure goes, are then sent to a remote dentist to review. And they also get a face-to-face examination, which is the reference standard. Our outcome is really to compare the findings of the remote dentist and the face-to-face dentist and check the accuracy. We'll also be looking at the urgency scores as well as end user satisfaction. That is both the young person and the provider. Overall, if this is proved to be successful, this will enable early detection of oral disease and access to essential oral health care. So one of the main challenges that we faced during the process, aside from what I keep saying, the gymnastics of the ethics, is security and ICT regulations within custody. So we had to really review the device specifications that were proposed by the IT department. Currently we're using an offline system because due to security requirements and regulations, we could not access the internet with the device, and data security was also pretty strict. So we had quite a lot of regulation and conversations and reviews, even with the system we're currently using to upload the photos. At the end of the day, we settled for RedCap, which provides an offline solution that helps us sync. It works on an iOS mobile device, which is the recommendation for Justice Health, that we use an iOS device. It allows image capture to take the photographs and to customize the forms specifically to the cohort that we're dealing with. And it also allows for encrypted storage and protects the sensitivity of the youth data. In addition, it provides data and audit trails and stamps, which is really good for security regulations. So just a quick flow chart of how this is all working in-house today with the team. I keep turning around because they're right here. Is that the recruitment is, we've been recruiting from the dental clinics, and the dental team has even extended that grace to allow us to work outside the dental clinics. And so within the clinic, we're currently in the dental clinic, and we have the GP clinic next door. So we recruit in the GP clinic. Leigh does the consent, and then I take the photographs of the young people. The photographs are uploaded onto RedCap mobile app, which is offline. And then once I take the photographs, the young person then comes and sees Nikki, who does an oral examination, a dental exam. And it's recorded on a specific screening form. When the photos are uploaded, they are then sent to a remote dentist who does the evaluation. We currently have 2 remote dentists who will be evaluating all the photos. Once that is done, then the information will then be analyzed, and we'll do the comparison, looking at the reliability and validity. What we're also doing is asking the satisfaction survey once they're done with the photographs, and that information will also be used to assess the acceptability of the model. I know that might be a bit too much, but this is how some of the photos look like. We take 5 photos of different views, and these are the photos that then will be assessed by the remote dentist. I'd like to just thank the team that has been so gracious in supporting this study, my primary supervisor, Professor Sullivan, and my other supervisors, Leigh, who is here today. We have associate investigators, Kate, Nikki, who is here, and Shauna is an Indigenous oral health therapist who's been assisting us. I'd also just want to really thank the health staff from Youth Justice, and they've been really, really supportive, and my funding comes from the university. That's it, so I'll hand back to Leigh.
Thanks for that. That was amazing bunch of research you guys are doing. And I really commend you all for getting that trial up and running in a youth justice setting. I'm sure the ethics is a bit of a nightmare. I'll open it up to questions, but just put your hand up in the chat if you have a question. I just wanted to start by asking though, and feel free to jump in, whoever's best at answering this. What's the current process for someone in youth justice to see a dentist? So if a kid says, "Hey, I want to go see a dentist," how long does that take? Like, can you walk me through the actual process?
So usually in the youth justice centres, the nurses would fill in a oral health assessment form, like a triage form. So in the adult centres, we have a call line, so a dental hotline, basically. And in line with state policy, every patient has to be triaged in accordance with sort of New South Wales health policy. And then once they're triaged, they're placed on a waiting list, and basically when they get to the top of the waiting list, they get booked in to be seen. Look, waiting times, they're not so bad in the youth centres because the numbers are lower. But generally, I think when we've looked, and this was done a few years ago, but most patients are waiting sort of 5 times longer than they would be in their local community to see a dentist. And that's just because of resourcing.
Yeah, yeah. Oh,
And I
thanks.
think because of our current approach is not population based, so not every young person sees the dentist currently, which is what we're trying to develop an argument for with our study. So unless the young person actually answers positively to the questions in the initial assessment about do they have pain or have they got redness or swelling or anything like that, if they answer no to those questions, they wouldn't be put on the list. They can also nominate themselves for the dentist in between, after the initial assessment if they get pain, but it's not comprehensive. And we know that a lot of young people have caries, sometimes rampant caries, without any pain, redness or swelling. So we feel like we're missing a lot of people with that approach.
Yeah, definitely.
Yeah,
Thanks.
because often by the time they've got pain, it's a bit too late then. And I think that's one thing that we're hoping with this, we're kind of noticing with the study, is that they're a lot more receptive to treatment. They think, oh no, my teeth are fine. And then seeing the photos and then coming in for an assessment and being told, oh, actually you have quite a few holes that need to be filled, because they can see it, they will actually accept being booked in, whereas ordinarily they might refuse to come and see the dentist.
Yeah, thank you. I'll just get people, if you're comfortable, to put your cameras on. It's always great to see everyone's faces. Graham, next question?
Yeah, thanks, Darcy. Just a question in relation to, so very interested about the oral health service, particularly around, I understand taking the photos in relation to inside a person's mouth. I assume that's really just to assist regarding the triaging and prioritisation, because still at the end of the day, they will still need hands-on treatment elsewhere.
Yes, that's right.
Yes, I think what we're trying to really focus on is the screening part of it. So the initial screening is what we're hoping to address with this study. As Leigh mentioned, currently when they come into custody, they're just interviewed. You're asked, do you have a dental problem or not? And there's a list of potential answers that then get them triaged to get care. So with this, we're just improving the triaging process and reducing the reactiveness of the current system to just react when there's pain. So by triaging them, then we'll know who's priority and who's not priority. And by testing this, the face-to-face dentist still remains the gold standard, but we want to see if the remote dentist can triage the same way. So you're right, at the end of the day, it's not a treatment that we're proposing, we're just proposing to improve the screening process of it.
I think what we're trying to do is make it, in addition to increasing accessibility, and make it more equitable, so that we're able to see who are the more serious cases, to prioritise them for the dentist. What we would like to do eventually is develop a business case for the organisation to take seriously and fund, whereby we have enough resourcing for our in-house dentists, but we also have some agreed established referral pathways through to our public dental services for our remote and rural centres, so that we've got more timely access to face-to-face dental care for the young people. And we'd also like to, through the screening process, if it shows that a young person's got good teeth and they don't actually need to see the dentist, that our nursing staff and potentially our GP staff can provide some fluoridation and some health promotion instead. So at the moment, we're not really sure who's who when they come into the zoo, so to speak. So it gives us that opportunity to do all of that extra capacity around this. Not going to reduce numbers by any means, but it's going to make it much more accessible and equitable.
Oh, that's good. I mean, it's one of those particular challenges in terms of, trying to build fairness in the system and make sure that there's, an objective clinical prioritisation that actually occurs. Thank you.
Can I just chime in and say that one of the unexpected findings is that, and I know Nikki's echoed this already, is once they see the photos, it's like the whole conversation changes. It's an icebreaker. There's this interest in discussing their teeth. And I think we're seeing it as a really good icebreaker for oral health promotion. and creating awareness about their oral health above and beyond everything else we're trying to achieve.
And the really lovely thing, I think there was a lot of thinking that it was going to sink. You know, we put in a Triggs grant and we came really close to getting awarded money. But the thing that they said is, we don't know whether the young people will accept this. And we haven't had a single young person decline. And how many have we done, Caroline?
I think we're about at 76 now, and we've had no decline. They've all accepted.
And they've all enjoyed the experience and the engagement. So.
Yeah, excellent. Well, congratulations.
Thanks. Stuart, did you have a question, or was that answered?
Yeah, sorry, it's a bit of a nerdy research question, but it's just, I mean, it's just amazing to see how much work you guys are doing. And Sarah Pellicano, who's here, did a review recently of all Australian Justice Health research, and I just had a look at the almost half of the youth justice health research papers in Australia ever came out of New South Wales. So I guess you guys must be doing something right. I guess my kind of, other than kind of trying to flatter you a bit, my question is just if you have any kind of words of wisdom about enabling environments and how to do this research and do it well. Yeah, there are so many challenges to doing health research in youth justice settings, and Leigh, you referred to some of them. I mean, mature minor issues around consent is just one of them. Do you have any kind of pearls? I realize we're almost at time, but I'd just love to hear your words of wisdom around this.
Go first. Look, working within the centres with youth justice and with the health, Justice Health staff has probably been, and with the young people, has been the easiest part of it, I would say. Everyone's leaning in because they can see the value of this project. The most difficult aspects really have been ethics, to be honest. The many barriers that ethics put up, some of them justified, some of them rather pedantic, I have to say. I think some of that obviously has to be done. I mean, just to give you an example, Stuart, we engaged with the Aboriginal reference group through the University of Newcastle, which are a bunch of independent people who come together in that institution to look at research and provide advice. And we felt that was adequate for our reference group. And we got to kind of the end of the ethics process and we're running out of time and we have to start. And we were told that was not adequate as an independent reference group. And we had to then go and find a whole bunch of other people to provide independence to be a new Aboriginal reference group. So that was really quite tricky, wasn't it, Caroline, at the 11th hour? Yeah. But we found some fantastic people who were supportive, who came into it. And a few other quite tricky things that they threw our way. But that was really the trickiest bit. I think engaging with staff on the ground. So, we made sure that we had good representation from youth justice, from the clinic centres, from oral health, from other parts. I think that's really, really important, keeping people involved in the study. Yeah, do you have any other advice, Nikki?
I mean, I probably, if I was sharing from a perspective of a PhD student who had never worked in custody or within the Australian context, I would say that having Leigh as one of my supervisors who's familiar with Justice Health was really helpful, and Liz also, who has done research previously. The team, the dental team, in terms of their support and interest and passion for this work has just made it a very easy process that all the other hurdles kind of make it worthwhile. So that it's just been one of those studies you share it. Even the youth justice team come and bring in the young gentlemen here. They find out about the study and they just get excited about it, and they kind of just want you to succeed. So it's been really good engagement, and I think the co-design process was really great from the beginning.